I'm presenting today on rheumatoid hand. So since the advent of disease-modifying anti-rheumatic drugs, we've reduced the number of patients seeking hand surgery. But patients with rheumatoid deformities still do seek surgical intervention for improving their pain, function and aesthetics. It's a very broad topic, so I've chosen to focus just on a few key aspects of things like patient examination, imaging, as well as tendon pathologies and finger deformities, and I'll touch on some of the aspects of preparing rheumatoid patients for surgery. In terms of examination, the key look, feel, move still stands. In terms of observation and appearance, looking at skin creases, swelling due to synovitis, tenosynovitis, deformities including characteristic ulnar digital drift and swan neck, and Boutonniere deformities, prominent ulnar as in caput ulnae, as well as volus subluxation of the wrist, and subcutaneous rheumatoid nodules can also be observed. Feeling for warmth, boggy swelling of the joints, tendon sheaths, tendon thickening and nodules. Checking for active and passive range of each joint, evaluating fixed and flexible deformities and tendon ruptures, looking for centralised extensor tendons at the MCP joint through ROM. And a number of special tests can also be utilised. So Bunnell's test evaluates intrinsic tendon tightness by looking at the passive PIP joint flexion with the MCP joint both flexed and extended. A positive test occurring when PIP joint flexion is limited, when the MCP joint is extended, which puts the intrinsics on stretch. Elson's test, another one.
Elson's test is a good clinical sign to look for central split disruption. The finger...
basically Elson's test assesses integrity of the central slip. So it involves flexing the PIP joint against a flat surface, such as the edge of the table, and asking the patient to extend their finger. So for a normal patient, when they extend using the central slip, the lateral bands remain quite lax. So they'll have good extension, but the DIP joint will remain quite floppy, as you can see here, with him being able to move that DIP or distal phalanx. If the central slip is injured, the extensor tone at the DIP joint will be increased as the lateral bands will be recruited and tension will be transmitted. And so when they do this extension, the DIP joint will become quite firm and unable to be moved easily. So that's a positive test there. You can also check the tenodesis effect, so looking for a flexed position of the fingers when the wrist is extended and a extended position of the fingers when the wrist is flexed. Hands should be symmetrical, fingers should lie in a smooth cascade, and any deviations can help be clues such as to tendon rupture and other pathologies such as sheath scarring. So functional assessment is also really key part of assessing rheumatoid hands. So looking at the patient performing different things, Solomon hand function tests can be used to assess ability to do activities of daily living and also assess surgical results. So power grips such as turning a doorknob or unscrewing a jar, precision grip, writing with a pen, using pulp pinch grip to pick up a coin, lateral pinch to turn a key, and hook grip to hold a briefcase. Then in terms of imaging, plain radiographs are the mainstay, looking at joint congruity and alignment, joint spaces, looking at narrowing, any cyst formation, marginal erosions, and periarticular osteopenia. And advanced imaging, MRI, CT, even ultrasound can be used to provide further information to confirm findings of a thorough exam. So in terms of digital ulnar drift, there's usually an extended tendon ulnar vector involved. So normally flexor extensor tendons have a small ulnar vector as they approach the MCP joints and the ulnar direction. This can be an increased force in rheumatoid hands due to soft tissue dysfunction, so subluxation of extensor tendons ulnarly at the MCP joints, tightened intrinsics pulling them in that direction, the fingers in that direction, and the MCP joints can also contribute by subluxating ulnar and volarly, following weakening of the collateral ligaments, volar plate, and radial sagittal bands. Non-operative treatment with splintings is limited, and effectiveness, compliance is a major issue here. So in terms of operative treatment, the goal is to rebalance ulnar and radial deviating forces, so aiming to overcorrect the deformity a bit, as it usually can recur a little bit, or to an extent. So treatment choice depends on whether the joint is preserved or not. So in early disease, when it is, soft tissue procedures can be performed. So you can release, you can release the ulnar-sided deforming structures, so ulnar sagittal band and the intrinsic tendons, and imbricate or reconstruct the radial sagittal band, reconstructing using an ulnar slip of the extensor tendon. So where the joint is destroyed, MCP arthroplasty as well as soft tissue rebalancing can be an option. So combining arthroplasty with silicone implant spaces such as this, which are traditionally used, with releases of the ulnar collateral ligaments, and then again release retensioning of the radial collaterals. This can have a few issues with subluxation, recurrence, stiffness, and implant fracture of these silicone implants. So Swan neck and Boutonniere deformities are very characteristic of rheumatoid. Swan necks are characterised by proximal interphalangeal joint hyperextension as well as DIP joint flexion. It can be from pathology at MCP joints as well as the PIP and DIP joint. So this can be often caused by terminal tendon rupture from distal interphalangeal joint synovitis. Patients with swan neck really struggle. They can't really grasp objects because of this hyperextension of the PIP joint. So corrective surgery can have satisfying results. So for non-operative treatment, patients with flexible deformities can use a ring splint. Operatively, patients must have the deforming forces addressed. So where the joint is preserved, this can be overcome with soft tissue reconstruction. So an example of this, FDS tenodesis. So this uses a slip of FDS sutured back onto itself over or through, as you see here, the A3 pulley, or you can also attach it to the proximal phalanx. And this creates basically a static volar restraint against hyperextension of the PIP joint. In terms of tenotomy of the central slip, as you see here, tenotomizing where the red bit is, this can reduce hyperextension of the proximal interphalangeal joint. Other options that also aim to create restraints to hyperextension of the proximal joint are spiral oblique retinacular ligament reconstruction, volar plate advancement, and dermodesis. For rigid deformities with the joint preserved, extensive soft tissue release can be used to try and restore some of the range. And for patients with joint destruction, arthroplasty infusion might become necessary. Arthrodesis has the most reliable results. If the DIP joint is the cause of deformity, DIP fusion actually can offer a really reliable correction, and patients can be quite happy with the results, as it actually restores a patient's ability to make a fist and grasp objects. And soft tissue balancing may be required to get them into a position for optimal fusion. Arthroplasty is very limited due to the lack of good ligamentous supports in the rheumatoid setting. as the soft tissue is often damaged and attenuated by the rheumatoid inflammation. So Boutonniere deformities, these are flexion of the proximal interphalangeal joint with then hyperextension of the DIP joint. So in this setting, basically, PIP joint synovitis attenuates the central slip and dorsal capsule, as you see here, causing rupture. The head of the proximal phalanx can actually then buttonhole through, increasing flexion. And the subluxation of the lateral bands in a volar direction can contribute to PIP joint flexion as well, while tightened oblique retinacular ligaments lead to hyperextension contractures distally. And these patients have your positive Elson's test, as we saw in the video. So splinting can be used for flexible deformities. These patients can often compensate for a deformity and they're able to make a fist, so it's somewhat less disabling than swan neck. And surgical correction actually can stop patients being able to flex their PIP joints, and this can actually be problematic for function. So decisions to proceed for surgery, especially for the ulnar digits, which are really important in that grip position, must be carefully considered. For flexible patients, flexible deformity patients can have soft tissue procedures, but these do have somewhat unpredictable results with recurrence. So these can include extensor terminal tenotomy. This increases extension moment at the PIP joint to correct the deformity. The central slip can also be repaired or imbricated, but this can limit post-op flexion, and extensor reconstructions can be employed, but it's quite intensive with possibility of recurrent deformity in rheumatoid hands. So again, fusion can be really useful, particularly for patients who are painful and have functional limitations with joint destroyed. But again, need to think carefully whether this will limit patients' grip. Arthroplasty is also limited, as a significant resection of the proximal phalanx is required to actually get implants in a fixed, flexed PIP joint deformity. And this leads to a lot of instability with sacrifice in the collaterals. So in terms of extensor tenosynovitis, Doug talked a little bit about this a few weeks ago, but basically it's a frequent manifestation of the disease, and mostly tenosynovitis affects the extensor tendons at the wrist. You can see things like pain, as well as this tuck sign, which is a massive synovial thickening tracking with the tendons and bunching at the retinaculum during digit extension. Treatment, non-operative, is your first mainstay. Particularly DMARDs, rest, splinting, can use local steroid injections. Surgical debridement is advocated for patients who are refractory to at least 6 months of conservative treatment. This is because infiltrative tenosynovitis can then cause significant risk of tendon rupture. Debridement of the tenosynovium has quite good results in extensor tendons, recurrence rates of 10%, and it can reduce tendon rupture risk to about 3 to 7%. They use a midline longitudinal dorsal incision, incising and reflecting over the third or fourth extensor compartments, and debriding the tenosynovium sharply. In this operation, you can actually use oblique or Z-shaped incisions of the retinaculum to suture it in the lengthened position to help excursion of the tendons. But also some surgeons might split the tendon in half in a transverse direction and then actually lay half of the retinaculum under the tendons and suture that down to shield the extensor tendons from eroded wrist bones and then risk of attritional rupture. So in terms of rupture, attritional rupture due to dorsally prominent ulnar heads from Druge instability, volar carpal subluxation, as well as tenosynovitis. This most commonly occurs in the little and ring fingers, and Vaughan-Jackson syndrome is what we see in rheumatoid hands, although less with the use of effective medications, with the rupture of dorsal extensor tendons starting with the little finger from ulnar to radial. And here you can see, just for those who haven't maybe seen it, some of the extensor tendon rupture of the ring finger, quite obviously seen here with the patient extending.
That's fine.
So treatment is really operative. Non-operative is rarely warranted. So in terms of cause, if arthritis or instability of the DRUs or caput ulnae is a issue, this should be addressed in conjunction with soft tissue reconstruction, so distal ulnar resection, Sovco-Pangi surgery with pseudoarthrosis forming of the ulnar with the DRU's arthrodesis. And the tendon injuries can be managed, repairs being limited because rheumatoid hands have really poor quality tendon, so mostly via reconstruction, including transfer, tenodesis and grafting. So in terms of transfer, donors include extensor indices, as well as ECRL, ECRB, even Flexor superficialis. So for the small finger extensors, which are most commonly affected, you can use the extensor indices, transferring it to the distal stumps of extensor digitorum minimi, as you see on the right here and on the left. These repairs can be using either side-to-side or Pulver-Taft weaves. If both ring and little fingers are ruptured, you can actually transfer extensor indices to both of these. And if all tendons are ruptured, which is very uncommon due to misdiagnosis, you can actually use the Flexor digitorum superficialis from middle and ring fingers to power the extensors by tunnelling through the interosseous membrane. So in terms of tendon grafting, it has pretty similar results to transfer in some limited literature studies. Palmaris longus most commonly used where present. Fourth toe extensors can also be possible donors. And here you can see just an example of how this has been used for EPL rupture, albeit not in a rheumatoid hand. I just thought useful to demonstrate the concept perhaps for some of the residents. And then tenodesis, you can tenodese the EDC to adjacent stumps to the adjacent intact tendons. And then flexor tendon pathology are reasonably similar with some differences. So you can get triggering more with this because of the increased bulk of the tendon in the sheath, causing triggering at A1 pulleys or in the carpal tunnel, as well as carpal tunnel syndrome. Early surgical intervention is really important for the flexor tendons because rupture has really, really bad results, particularly if it's in the fingers in the sheaths and has poor and inconsistent results. You can utilise a number of incisions, so a palmar transverse incision or carpal tunnel incision, delivering each tendon to the wound to perform sharp tenosynovectomy, as well as Brunner incisions on the digits. Recurrence is actually 30%, so 3 times that of extensor pathology. So the causes for flexor tendon rupture are similar to that of extensor tendons, also looking at things like volar carpal subluxation and volar subluxation of the metacarpophalangeal joints and osteophytes in the carpal tunnel. FPL is most commonly affected in the flexor tendons. So Manifest lesions or syndrome is when this is due to abrasion on a volarly displaced scaphoid. And prevention is really essential, as treatment has a guarded prognosis and is less effective than in repair or reconstruction, of extensor tendons. So operative treatment is the mainstay due to the significant functional impact of a flexor tendon rupture. Management depends on which tendon is ruptured and where. You can use tendon grafting and transfer performed by an extended carpal tunnel release and Brunner incisions. For FDS ruptures, you can actually just excise the FDS stump and perform a tenosynovectomy of FDP, as this will continue to be able to flex the interphalangeal joints. For FDP ruptures, if it's very distal, it might be minimally retracted and caught in the chiasm of FDS, and you can often advance and repair. If more proximal, you can excise the stump, perform a DIP joint fusion and tenosynovectomy of the remaining FDS. If both flexor tendons, superficial and deep, are ruptured, recovery of flexion is less likely, outcomes quite poor. You can use grafting, you can use the FDS tendon as a graft, as well as palmaris longus, and this can be done in delayed fashion as well after insertion of silicone rods to preserve the pulleys. And FPL rupture can be treated with tendon transfer of brachioradialis or FDS. And any bony deformities must be corrected to prevent recurrence. IP joint fusion can also be used when it's a proximal rupture, as mentioned, or if both tendons are ruptured. So treatment, we really require a collaboration with rheumatologists and hand therapists. For patients who don't have systemically controlled inflammation, surgery is basically futile. So we really rely on our rheumatology colleagues as the tissues won't withstand the inflammatory challenges of uncontrolled disease. Also, rheumatology inputs very important regarding medication management perioperatively to try and mitigate risks of infection, wound healing. So treatment algorithm, need to really think, will surgery actually improve the patient's function and give them what they want? So looking at what the individual patient has, which joints are involved and the disability. This can use a therapist assessment at home, in the workshop or in the kitchen. Having a thorough assessment of what the patient's motivations are. Is it they want to address pain, appearance, function? For a patient who has limited pain and reasonable hand function, these are really best treated without surgery. And it's quite important to give the patient all of the information here, not only about the surgery, but the limitations of outcomes for this treatment, and sometimes the quite lengthy rehabilitation protocols required, as we want to be sure they're going to comply with this before you undertake surgery. In terms of what you're treating, where patients have multiple issues, you want to look at lower limb corrections first to avoid stresses from crutches and walkers on reconstructed upper limbs, and as well as reconstructing proximal joints first. So for patients with ulnar digital drift, you want to correct radial deviation of the wrist deformity first before you correct ulnar subluxation of the MCP joints and the digital drift. So the key take-homes, as always, multidisciplinary care, I think of particular benefit here. Looking at, when we want to try prophylactic surgery, such as tenosynovitis versus reconstructive surgery, and knowing that you really need good disease control before patients should embark on surgery. Treatment should be aimed at cause, and particularly looking at what is causing the deformity or the issue, and addressing this, as well as the goal of addressing the patient. And patients, as always, need really thorough counselling regarding what do they want, can we actually deliver this, and what's the expected recovery and outcome for them, and is it going to recur? So thank you.